So myeloproliferative disorder is otherwise known as myeloproliferative neoplasm because of a particular mutation. So the mutation at times cut across the three cell lines, but at times specific for a particular cell line. Like BCR-ABL, specific for what? Is CML. CML. You have other mutations known as JAK2, Janus kinase 2, cut across polycythemia, cut across essential thrombocythemia, cut across myelofibrosis. You also have other mutations that can cause a loss of this negative feedback, such as the reticulin R, Cal R, or myeloproliferative leukemia mutation, MPN. So these two other ones and JAK2 cut across polycythemia, which is red cell, and so mutation affecting the cell line can cause uncontrolled production of these cells. So for example, if you have the BCR-ABL mutation, your normal WBC should be between 4 to 11,000, but without mutation you can have WBC as high as 200,000, 300,000, 400,000, 500,000. So that's the effect of the mutation. Similarly, if you have a JAK2 mutation that is almost always associated with red cell, you have polycythemia. What's the normal PCV for male? For male, it should be between 40 to 50%. For female, between 37 to 47%. And for neonates, it's between 44 to like 64. So imagine someone having a JAK2 mutation. PCV can get as high as 60%, 70%, going about with a PCV of 70%, and it is an abnormal condition. It's a neoplastic condition. Similarly, if it's affecting the platelets, the normal platelet count can be between 150 to 400. You now have individual with platelet count of 600,000, 700,000, 800,000, 900,000, 1,000,000, 1.2 million platelet count. You do a full blood count, you see 1.2 million. What's the implication of increasing the cellular content of the vessel while the plasma remains the same? What do you think what will be the implication? Sorry? Increase viscosity. Increase viscosity. So it's like pouring garri inside water. You have little quantity of water, you have plenty garri. You are going to have, it's going to be, you take a lot of garri at your level, except the children of the rich that are here. So you should understand what I mean very well. So we'll be talking about myeloproliferative. So like I said, it's formerly called MPD, but it's now known as MPN, myeloproliferative neoplasm. So these are the diseases that are under MPN: chronic myeloid leukemia, polycythemia vera, myelofibrosis. MF is myelofibrosis. It could be primary, it could be secondary. Polycythemia too can also be primary or secondary. We'll talk about it. essential thrombocythemia that is affecting the platelets. Then did she talk about hypereosinophilic syndrome, eosinophilic leukemia? Eosinophilic leukemia? No, she didn't talk about eosinophilic leukemia. Hmm? No. Okay, maybe next week I will take her. And systemic mastocytosis. So the CML is the only leukemic component of the, I mean, the others are non-leukemic. CML is the only leukemic part of the MPN. So this lecture we just talk about at least three. Talk about myeloproliferative. I'll talk about polycythemia vera. We'll talk about myelofibrosis, and we'll talk about essential thrombocythemia. So we can continue next week, and that's why you have MPN 1 and 2. Okay, then there is MDS that is not classified under MPN, myelodysplastic syndrome. So we'll bring that up next week while we are trying to conclude this. So we'll start with polycythemia vera. Okay, but before then, this is just to remind us of the stem cell. This is from the hematopoietic stem cell, we give rise to myeloid committed stem cell, and then the lymphoid committed stem cell. And this is what we are concentrating on this side of the diagram. The myeloid committed stem cell can eventually give rise to the red cell, give rise to the platelets, and give rise to the granulocytes. So if there is a mutation at this level, so it will cause increment in this and this at the same time, because there is a common source. So this is what we'll be talking about. So we'll be talking about how the mutation is going to affect the red cell, which is known as polycythemia vera, how it's going to affect the platelets, which is essential thrombocythemia, and it's also myelofibrosis, because myelofibrosis also has a component of platelet disorder. We've talked about chronic myeloid leukemia already, so we won't discuss that again. So, but polycythemia, like I was saying, that the normal PCV for male is 40 to 50 according to your laboratory manual. For female is 37 to 47, and for neonates is 44 to 64. Why is that of the neonate higher than you and I? Who knows? Why is the neonate PCV, why should it be higher? 60% in neonate is normal. It has to do with eh? Speak up when you get to the hostel. No, I know how you speak. I hear your voice from outside. Eh? Speak up now. It's not blood volume. Why is the neonate is why?
Because of their something you did them, I've forgotten it now. But they are alpha and
You are part of the class now. You are looking as if you are not part of us. Hmm?
they need more blood.
They need more blood. What is the component in neonates? Hemoglobin F is higher, and will shift oxygen distribution curve to the left, and then stimulate erythropoiesis. If you have plenty of hemoglobin F, it's going to shift oxygen distribution curve to the left, and then stimulate. Once oxygen is shifted to the left, erythropoiesis will be stimulated. That's the reason why neonates. So if you have, there are various types of polycythemia actually. Polycythemia could be true polycythemia or apparent polycythemia. It could be true or relative, true or relative, true, absolute or relative. It's different from that classification. Absolute or relative, or true or apparent. Okay, if you want to classify polycythemia based on red cell mass, the quantity of the red cell in you use that classification as absolute polycythemia when the red cell mass is higher than expected, or relative polycythemia when the red cell mass is normal but PCV is increased. PCV is increased but red cell mass is, if you go out, if you don't, if you don't, red cell mass is higher in absolute polycythemia, and then PCV is also high, but in relative, red cell mass is normal. That's if you count, if it's possible to count the number of red cell in you, 1, 2, 3, is not higher than normal, but the PCV is high. That's a relative polycythemia. So what will cause a relative polycythemia, or what will cause a relative polycythemia when the person does not have mutation, JAK2 mutation, but the PCV is high?
Dehydration.
Dehydration, you've seen it. Yeah. When you are, once you are, what will cause dehydration? No, that's not
Can be
disease.
due to water intake or excessive water loss.
Excessive water loss. Excessive water loss in this part of the world. If you are in the desert, you can be dehydrated and there is no water. But in this part of the world, is vomiting and diarrhea. If you have severe vomiting and diarrhea, like in cholera, you are losing blood plasma. You are using water through the vomiting and diarrhea, and then the plasma will drop, and then it will appear as if the PCV is high, because you know PCV is a relative relative term between the blood cells, the red cell, and the plasma volume. You've done PCV manual. So if you lack plasma, then it will appear as the PCV is high. So it is not, the red cell mass is still the same. The red cell mass is still the same. How will you treat that?
When you give fluid.
Give fluid, that's all. Just give fluid, and then the plasma volume will also go up, and then the PCV will. But there is a condition called stress Geisberg syndrome. Stress can, the mechanism may not be known, but stress can cause the PCV to go up for one reason or the other. But the other one is when the red cell mass is actually increased. When the red cell mass is increased, then it could be primary polycythemia, primary or secondary polycythemia. The red cell mass is actually, the erythropoiesis has been overstimulated and is producing more red cell than normal, unlike when the plasma volume is just low, and then it appears as the PCV is high, but there is no bone marrow stimulation of erythropoiesis. That one is still stable. So that's why the red cell mass will be normal in relative but increased in. So maybe we should talk about secondary polycythemia before we talk about primary polycythemia. These are the listed causes I have here. Listed causes of secondary. Secondary meaning that there is a disease ongoing in the body that is resulting in increase in the PCV. So you can group them too into, usually if you want to start from the head to the pelvis, or you can group them, these diseases of secondary polycythemia, into appropriate stimulation for erythropoietin and inappropriate stimulation. That one is not here. but I'm just so you can document it. Appropriate stimulation of erythropoietin and inappropriate stimulation of erythropoietin. Maybe I should start with the inappropriate stimulation of erythropoietin, then I'll come back. I'm talking about secondary now. I hope you are still on the same page. Then after that, I will talk about primary polycythemia. And I said you can group them as appropriate and inappropriate. Inappropriate is usually malignant conditions that have ectopic production of erythropoietin. What do I mean by ectopic production? Producing erythropoietin apart from the natural site of production. What are the natural site of erythropoietin? The kidney and the liver. You now have a cancer that is secreting erythropoietin, and the erythropoietin being secreted will stimulate erythropoiesis. And then, so what are these cancers? Okay, renal cell carcinoma, anything affecting any kidney cancer will cause massive production of erythropoietin, because that's where the nephroblastoma can also cause ectopic production of erythropoietin. Because erythropoietin is also produced in the liver, if you have cancer of the primary liver cell carcinoma, primary liver PLCC can also produce ectopic production of erythropoietin. Bronchial carcinoma, that's the lungs, can also take up the responsibility of producing abnormal production of erythropoietin. So you will also have uterine fibroids, cerebellar hemangioma, hemangioma affecting the cerebellum can also produce erythropoietin. So uterine fibroid usually will produce anemia. If you have fibroid, you have anemia, but you should have anemia because of the associated bleeding, but it can also stimulate erythropoietin production. But usually they don't present with polycythemia. If you have fibroid, you present with anemia. So, but for the appropriate stimulation, that is inappropriate o. Inappropriate because of an ectopic. We are still talking about secondary polycythemia, and I said it could be appropriate stimulation and inappropriate. So inappropriate usually cancers, but for the appropriate, hypoxia. So the body will, if there is hypoxia, body will stimulate the marrow to produce more erythropoietin. And if you have erythropoietin, so any condition that will cause hypoxia usually associated with appropriate production of erythropoietin. For example, high altitude, because the higher you go, the lower the oxygen concentration, and that is why people in mountainous area have a higher PCV, living in born and brought up in mountainous area, like in Kenya, Tanzania, East Africans, it's like mountainous, Jos. So they have a higher PCV than people living in Lagos, sea level. So because the higher you go, the lower the oxygen, and the body will be forced to stimulate. So you can also have chronic obstructive airway disease, COPD, because this can also cause hypoxia. Example emphysema or chronic bronchitis can also cause hypoxia. Okay, so obstructive sleep apnea. So some people will be sleeping and then breathing will stop occasion abruptly while sleeping, and just wake them up and start panting for breath because of maybe there's a growth in the larynx that is obstructing the airway. So this can also cause polycythemia, secondary polycythemia. Then if you any condition that will shift the oxygen curve to the left will stimulate erythropoiesis, such as methemoglobin. Methemoglobin is when you have iron ferric iron instead of ferrous in the hemoglobin molecule. So it's going to cause oxygen curve. Anything that will cause methemoglobinemia will cause a problem. Congenital cyanotic congenital heart disease. Cyanotic congenital heart disease such as tetralogy of Fallot, transposition of great vessels, pulmonary atresia, transcorpid atresia, all these will cause hypoxia and then stimulate erythropoiesis. Okay, we see a lot of children with congenital heart disease. PCV is 80%, PCV is 90% because of the cyanosis, and then there is hypoxia. Smoking can cause hypoxia. Smoking can cause hypoxia by damaging the endothelium of the trachea, larynx, and then reduce the entry of air into the lungs. So chronic smokers can have PCV of 60, 70%, 80%. They don't have mutation. Secondary polycythemia do not have mutation. It's only when you have primary. So those are the cause, but there are more, but these are usually. And so I'm going to talk about primary polycythemia. Like I said, in primary polycythemia, there is a mutation affecting the release of erythropoietin, and that mutation is called JAK2, Janus kinase 2, V617F, and it is also known as polycythemia rubra vera. Polycythemia rubra vera. That's the primary. Unlike the secondary, it's not polycythemia rubra vera, but it's the primary that is known as polycythemia rubra vera because of the mutation called JAK2 mutation. So we now, because the mutation has been identified now, so you now have an inhibitor to the mutation, JAK2 inhibitor. Although it's not affordable in low medium country, it's called ruxolitinib for patients that have been proven to have JAK2 mutation. Jakafi, it's called Jakafi, ruxolitinib. So because the red cell is very high, the plasma will be low. So the ESR too will be low. That's one thing that is associated with polycythemia rubra vera. So, like I said, in true polycythemia, the red cell mass in male is usually 30 to 35 mils per kilo. If you are weighing 10 kilo, if you have a red cell mass of 30, that means you have 300 mils of red cell mass. If you are weighing 20 kilo, that will be 600 mils. But if it's higher than 35 mils of per kilo, that's when you can say the person has elevated. But for female, usually 28 to 32 mils per kilo. So any red cell mass higher than 32 mils per kilo in females is known as having, it's going to cause polycythemia, that's elevated PCV. And then because red cell mass require injection of radioiodine to measure, we are going to be injecting radioactive substances. You withdraw like 5 mils of blood, draw 5 mils of blood, label the red cell with a radioactive iodine, and then inject the labeled radioactive iodine red cell back into the body, and then measure dilution. So and then you will be able to say, okay, the the radioactive red cell to the injected radioactive red cell to the total red cell volume is so and so. So the higher the dilution, the so when you inject the radioactive, you measure relative to the red cell available. The higher the red cell, the lower the dilation, or the higher the dilution. So I can't really recollect how it is done, but if it's higher than 35 mils per kilo in male, because we don't do it again, the discovery of this Janus Canis 2 has made the use of red cell mass old fashioned, because you don't want to be injecting radioactive substances in human because of the risk of secondary malignancy. So JAK2 is a tyrosine kinase, just like you have BCR-ABL, which is also a tyrosine kinase, and but the specific JAK2 is specific for erythropoietin. So once it's mutated, it will be stimulating production of erythropoietin. So viscosity is a major challenge with red cell because the red cell volume is higher in the same size of vessels and the plasma is lower. It could be occluding microcirculations such as the air, the cerebral vessels, the ear. So and then it will cause hyperviscosity syndrome. And because the spleen will have more responsibility of destroying red cell, because you have plenty of red cell, it's going to cause enlargement of the spleen. And then because it may also affect platelets, erythropoietin also supports. The platelets are abnormally produced, despite their high number, they are not properly produced. So there will be qualitative platelet disorder, and then that may be associated with bleeding. But then there is headache because of the occlusion of the cerebral vessels, can present with headache, can present with deep vein thrombosis if it's affecting the vein, can present with arterial thrombosis if it has cerebral thrombosis if it's attending occluding the artery. Then there is hypertension, but because this disease is seen in the elderly, the median age of presentation is between 55 to 60 years. Hypertension is a disease of the elderly, so we are not sure whether it's the disease that is causing the hypertension or the hypertension is normal for that age. So but hypertension is seen in 1/3 of patients. There is a low ESR, okay, because the ESR will be low if the red cell volume is high. So but there is also what is known as pruritus after hot bath. Pruritus, they have itching, maybe due to histamine release, because it's not only the red cell that is affected, white cell is affected, platelet because it's at a higher level. So histamine may be released in excess and cause. So there is what is called white cell alkaline phosphatase is found in white cell too. So once you have elevated white cell, if you measure the leukocyte alkaline phosphatase, it will also be increased. So, but if you do APTT, it may be mildly prolonged because in the patient, because you have plenty of red cell than plasma, so it's going to distort the 1:9 ratio of the plasma, and so that's the explanation for it, and the whole blood and the red cells. So it is not that the patient has abnormal bleeding disorder. So before this JAK2 was discovered, they were using polycythemia vera study group classification, which I didn't include. I didn't include that in this slide. So you need to. So there are two types of classification, or three. You have the polycythemia vera study group. You have the British Committee for Standard Hematology, which is what I have here, and you have the WHO classification. So the polycythemia vera study group was used in the past because there was no JAK2 then. So they based it on red cell mass, and there are major and minor criteria for polycythemia vera study group. The major criteria are about 4, and the minor criteria about 4. So the diagnosis is made. We have major criteria 1 and 2, and 3 or 4. Major. I'm talking about major now. There are 4. 1 and 2 must be there, plus 3 or plus 4. If 3 and 4 are not there, 1 and 2 must be there, and then 2 minor. I'm going to list the minor and the major for you, so that it will make more sense to you. Okay, so but you gotten the criteria for diagnosis. 1 and 2 plus 3 or 4, or if 3 and 4 are not there, 1 and 2 plus 2 minor. So the first one is that red cell mass is greater than 35 mils per kilo in male, and greater than 32 mils per kilo in female. Red cell mass greater than 35 mils per kilo in male, and greater than 32 mils per kilo. I said it's not in the notes. It's not in this note. So that's number 1. But like I said, nobody does red cell mass because of the risk of causing secondary cancer in the attempt to measure red cell mass, because you are injecting radioactive iodine, and then the person can develop cancer of other types. So the second one is arterial oxygen saturation greater than 92%. Because if you have plenty of red cell in you, oxygen saturation will also be high. Arterial oxygen saturation greater than 92%. How do you measure arterial oxygen saturation? Pulse oximeter. You use pulse oximeter to measure arterial oxygen saturation. So number 3 major is clinical splenomegaly. If you can palpate the spleen, then it's a major criteria. And number 4 is evidence of abnormal clone of red cell. If you can prove that this red cell is malignant, abnormal form of red cell is number 4, which you may not be able to do in this part of the world. Okay, but for minor is first minor is platelet count greater than 400,000. In the absence of iron deficiency, platelet count greater than, you have proven there is no iron deficiency, and because iron deficiency can stimulate secondary thrombocytosis. So if there is no iron deficiency and platelet count is greater than 400,000, it's a minor number one. Minor number two is when the WBC is greater than 12,000 in the absence of any overt infection. If there is no infection, because infection can stimulate leukocytosis. Okay, so minor number three is when the neutrophil alkaline phosphatase that I mentioned about earlier is greater than 100 nanogram per ml. The LAP, leukocyte alkaline phosphate, I said alkaline phosphate is also found in white cell. Where else do we find alkaline phosphatase? In the liver and the bone and the bone. But for white cell, if you can measure alkaline phosphate, the leukocyte alkaline, there's a way to measure it. It's greater than 900 gram, 900 nanogram, sorry, nanogram. That's the third minor. And the fourth minor is low ESR, erythrocyte sedimentation rate, is the fourth minor. So if you want to make a diagnosis, 1 and 2 must be there. That's red cell mass greater than 35 mils per kilo in male and 32 mils per kilo in female, and the arterial oxygen saturation greater than 92%. Then if you have that, if there is no spleen, there is no splenomegaly, and you cannot demonstrate abnormal clone, then you have to rely on your minor. The WBC should be higher than 12,000, and the platelet should be higher than 400,000. If you have the two, that's what they were using in the past. You don't need to do JAK2. Eh? Neutrophil is also high. I'm talking about the WBC generally. Hmm?
The third criteria that you gave us, we didn't get there.
The third,
Criteria you gave us.
I said leukocyte alkaline phosphatase. For minor, we are talking about minor. Leukocyte alkaline phosphatase greater than 900 nanogram, because leukocyte alkaline phosphatase is elevated in polycythemia vera. Okay, now that we can do JAK2, even in Lagos, we can do JAK2. You just send to lab and they do it for you. So we do JAK2 routinely for those that are in that age bracket. That's 50 years and above. 50 years and above. So the British Committee for Standard Hematology recommends the following investigation. Full blood count, at least you need a full blood count. It's okay, the PCV is high. Okay, you need JAK2, you need serum ferritin, then EUCR to rule out any renal secondary causes, and LFT to rule out liver cirrhosis, liver cancer. But we still have JAK2 is not seen in 100% of even those with polycythemia rubra vera. It's not seen. It's only 95% of cases that you have JAK2, but does not rule out polycythemia rubra vera. So we have criteria. These are the tests we do. So this is the British Committee for Standard Hematology classification of polycythemia rubra vera. For those that have JAK2 positive, you've done JAK2 and it's positive, the PCV must be greater than 52% in male and then greater than 48% in female, and then there is a JAK2 positivity. Then you can label person as having. Then 25% above what is, or 25% above what is expected for that age. You know, if what is expected is, for example, male is 50% maximum, or say 45%. What's 25% of 45? You add it over it. If it's higher than that, then you can use that. If you don't want to do that, just look at the PCV level. If it's greater than 52 in male or greater than 48 in female, and there's positive JAK2, you can label the person as having polycythemia rubra vera. But like I said, JAK2 is not seen in 100% of all polycythemia. You see how from 5%, 10% that are JAK2 negative. So those that are JAK2 negative, the PCV must be higher. The PCV must be 60%, because you are not too sure. You have not found JAK2. So you cannot use 52. The PCV must be 60% above in male and must be 56% in female if the JAK2 is negative. So then there is JAK2 negative, mutation is absent, and then you have not been able to find any secondary cause of polycythemia, such as smoking, such as COPD, such as high altitude, living in high altitude, such as cyanotic congenital heart disease, such as methemoglobinemia, such as abnormal hemoglobin that will shift, or such as inappropriate causes of erythropoietin release, like renal cell carcinoma, nephroblastoma, renal ischemia, PLCC, primary liver cell carcinoma, bronchial carcinoma, cerebellar hemangioma. You have not been able to prove that, and JAK2 is negative. That is the second criteria. The third criteria is you can feel the spleen. I'm talking about JAK2 negative now. For JAK2 positive, just two criteria. JAK2 is positive, PCV is greater than 52 in male, greater than 48 in female. You are good to go with the diagnosis. So, but for JAK2 negative, you need to check all this. Presence of acquired genetic ability. You have to exclude BCR-ABL, that is not CML, that is causing the PCV to go up. Okay, so but they are also minor, like in polycythemia vera study group, like thrombocytosis, platelet count greater than 450, neutrophils, leukocytosis, radiological. So for diagnosis of JAK2 negative polycythemia vera, you know, the diagnosis requires A1 plus A2 plus A3. A1 is that the PCV is more than 60% in male, 56% in female. A2, JAK2 is negative, and A3, no cause of secondary polycythemia. Those three must be present. Then, in addition to that, either another A or 2B will confirm the diagnosis. Another A, like palpable spleen, or another A, like presence of an acquired genetic abnormalities, excluding not BCR-ABL. BCR-ABL is CML. If you can prove that there is another genetic mutation, which you are not likely to do in this part of the world, or there are two minor, B minor, B1, B2. Okay, so you can make a diagnosis of JAK2 negative primary polycythemia. or JAK2 positive primary polycythemia. I hope that is clear. The WHO classification, you can read that. It's also, I can't remember that now, but it's part of what you should know. So these are, how do you treat somebody with PCV of 60 and then is complaining of headache, pruritus after hot baths, there is DVT, there is all this, or bleeding abnormalities. So you use venesection is the first line. What is venesection? Phlebotomy. You bleed, person will go and donate blood. Person will go and donate blood. And that blood, you want to give another pregnant woman bleeding. Why? You don't want to, somebody is bleeding and then polycythemic patient with a JAK2 mutation has donated blood. Why will you not want to give? Hmm? You want to seed the mutation in the marrow of the pregnant woman so that later when the woman is 50 years, woman will develop polycythemia vera. That's the implication now. If you do that, if you take such blood, that mutated red cell will go into your marrow and can cause polycythemia rubra vera for you. So you have to discard such blood. Okay, so as you are bleeding, patients will come 2 times in a week for phlebotomy. You draw like 500 ml of blood each time. And somebody, if you are donating blood, how much of blood do you draw? 450. It's 450 actually. It's the anticoagulant that makes it 500. So the person will become iron deficient eventually, because every red cell you are drawing, you are losing 1 milligram of iron. So how much of red cell do you have in 400 mils, 450 mils that somebody is donating? How much of red cell do you have? You have 200 mils of red cell. The remaining is 250 mils of plasma. Okay, and then you have 50 mils of anticoagulant. So eventually somebody is donating every twice in a week. So we'll be losing 200 milligram of iron per week, 400 per week. 400 per week. So the person will become iron deficient on the long run. Do you want to give iron? You want to give iron to treat the iron deficiency? You want to give iron to treat the iron deficiency? Huh? Yes.
I said no.
You said no. Why?
Yes, I can't really cancel.
There is no ongoing. You are going to stimulate. If you give iron, you'll be stimulating more erythropoiesis. So if you are bleeding, the more blood will be coming back. More blood. So you better leave the person iron deficient. So, but for elderly people, because it's a disease of the elderly, from 55, median age is 55 years. So you have to be careful for more elderly people. But as you know, what's the cutoff age for donation? 60 or 65 for somebody that has been donating. Why?
That's when they age, the body does not produce
Body does not produce enough
enough blood.
blood, and then there can be problem with the heart. So somebody with polycythemia, and then you are asking the person to come for phlebotomy twice in a week, person will die on the table. So you have to do it with sense. So you may not draw up to 450 mils in an elderly person with because of the risk of cardiovascular compromise. Okay, you can draw 250 mils at a time. Tell the person to come back another week. Give normal saline to replace the lost fluid. 250 means give normal saline, give like that, because a disease of the elder is not for you and I. Although I'm an elderly now, I'm in the bracket of the elderly. So, but other forms of treatment is we give hydroxyurea, you give radioactive phosphorus. Yeah, if you give this radioactive phosphorus, it's going to be, killing the red cells. And the beauty of it is that you just give one every 6 months, and then the patient can go to bed. Unlike coming for donation every twice in a week. But the problem with radioactive phosphorus is cancer, secondary cancer. So you are treating one cancer, then the patient will go and develop lung cancer, kidney cancer again. So it is not encouraged, but it works. It works. Then low dose aspirin is also good. Aspirin should be low dose, because if it's not low dose, it does not have anticoagulant effects. What's the milligram of a low dose aspirin? What's the milligram? What's the milligram of a low dose aspirin? The 75 milligram can be 100 in the US. 75 milligrams, called vasopril. But what's the milligram for aspirin that is used for pain, analgesic? Hmm? Is what? 300 milligram. So you used to make 600 milligram for adults. But for low dose aspirin, anticoagulant effect of aspirin is lost at that high strength. If you use 300 milligram, it doesn't have anticoagulant effect again, and that's what you are using it for here. So you must use a low dose, 75 milligram. I think it's one, you can get to 150 in the US, 150 milligram daily. So prognosis, can transit from polycythemia rubra vera to myelofibrosis, which we are going to talk about next. Person can transform from polycythemia rubra vera to myelofibrosis after some time, or transform into acute leukemia later. Okay, and the acute leukemia can be due to the treatment or diagnosis. If you have used radioactive substance to measure the red cell mass, or you have used radioactive phosphorus to treat patient, that's why they don't want to do red cell mass measurement again. And they've talked about what? Talked about, instead of red cell mass, JAK2. Talked about JAK2, because JAK2 just to draw blood and do PCR to check whether there is a mutation in that gene or not. Okay, so we'll talk about myelofibrosis. In myelofibrosis, the bone marrow has been replaced. The hemopoietic cells, your megakaryocytes, your platelets, your white blood cells, neutrophils, eosinophil, basophil, lymphocytes, your PCV, and your PCV, your red cell in the marrow has been replaced by fibrous tissue, or collagen, replacing the hemopoietic cells in the marrow. And it is a non-leukemic myeloproliferative disorder like polycythemia vera or essential thrombocythemia. So, like I said, there is excess collagen deposition, and if you have your marrow being replaced by collagen, then it's going to distort normal erythropoiesis, normal myelopoiesis, normal thrombopoiesis, everything will be distorted, and then there will be anemia. There will be anemia. The WBC may be low and platelet may be low. So disturbing the normal hemopoietic microenvironment. So it also interferes with bone marrow architecture, contributing to the hematological. So it disturbs the fat cell, the hemopoietic cell. Characteristics abnormalities seen in myelofibrosis. So the due to the increased intramedullary death, that's the bone death of megakaryocytes, okay, from the neoplastic clone, there is increased release of mitogenic substances which is normally stored in alpha granules of megakaryocyte and platelets. The platelet derived growth factor stimulates when the red cell, the micro megakaryocyte dies in the marrow, they release mitogenic substances such as platelet derived growth factor PDGF, and the effect is enhanced by platelet derived growth factor, basic fibroblast growth factor, and calmodulin released from the platelets, resulting from the death of the platelet. When they die, the alpha granules of the platelet will release all these substances, and this will inhibit collagenase. Collagenase is the one that ordinarily will break down collagen. So if you are going to be inhibiting enzymes that will break down collagen, and then the collagen will now take all the spaces in the marrow and then will distort the bone marrow architecture, distort hemopoiesis. So the implication of that is that you have so it could be primary, like I said, primary myelofibrosis, or it could be transformation from polycythemia rubra vera, okay, or CML or essential. It's just developing on its own, or patient has had polycythemia rubra vera and now transformed into myelofibrosis, which is the secondary type, or CML and now transformed into myelofibrosis, which is secondary type, or essential thrombocythemia transformed into, unlike the myeloid primary. So because of the bone marrow cannot function again, secondary hemopoiesis will now be called upon from the spleen and the liver. So liver and the spleen will now take over the function of the bone marrow, and in the process get enlarged. They get enlarged because you are overworking them. So most of them will present with massive splenomegaly. Massive splenomegaly. How do you describe massive splenomegaly? Big from where to where? Is big. The spleen is big the from the left to, is moves to the right iliac fossa. So most of the time is due to secondary hemopoiesis, and massive splenomegaly is almost always part of it. So but if how do you suspect that there is a myelofibrosis? Number one, there is a massive splenomegaly, there is anemia. Okay, if you do a bone marrow, you will not get any aspirates. Will there be aspirates? Because they've been replaced with collagen. So it will be dry tap. You try and try and try and try, you will not get any cellular content in your syringe. You will not get. So by the time you do that, you now do a bone marrow biopsy. What is the difference between a bone marrow aspiration and bone marrow biopsy? Aspirate is the cellular content that is stained with Leishman or or May Jimsa or Jimsa. MGG, May Grunwald stain or Giemsa stain or Leishman stain. What about the biopsy? You take a bone chunk and send it to the pathologist. So you may rely on that in myelofibrosis because you will not get any aspirates, usually dry tap. And the reason for the dry tap is because the marrow has been replaced with collagen and reticulin. So these are the laboratory features. Because the secondary hematopoiesis is taking place in the spleen, there is what is called a leukoerythroblastic picture. Immature, you now see immature white cell and immature red cell in the peripheral field because they are not properly produced. They are produced from an abnormal. That's what they call leukoerythroblastic picture. And teardrop red cell. You know about teardrop red cell? Yeah, like a teardrop. And big platelet. You see all these macrocytes. You see all this in the peripheral field. You can start suspecting myelofibrosis, dry tap, anemia, leukoerythroblastic picture, teardrop poikilocytes, megathrombocyte, macrocytes. If you see all this, yeah, then there is a dimorphic blood picture of megaloblastosis coexisting with iron deficiency, but red cells, because everything is distorted because the red cell, the white cell, the platelets are coming from an abnormal site such as the spleen and the liver. So these are the other features in the laboratory. If you do a chromosomal analysis, in 40% of patients show chromosomal abnormalities, and 70% of these have deletions. We do the karyotyping. So this is usually the cause 15789 1320. You can this will and also aid your diagnosis. So there is serum uric acid and LDH increase due to ineffective erythropoiesis. The red cells, the white cells are destroyed abnormally and will cause release of the cellular contents, increased lysozyme, increased APTT and INR as a result of the deranged LFT, increased alkaline phosphatase. This alkaline phosphatase, where is it coming from? No, you are not following. It's in the liver. You are talking about the liver, yeah. It's the liver. Decreased albumin, cholesterol, and lipoproteins. These are all abnormal red cells that are abnormal. So, like I said, aspiration is usually dry. You will try and try and try, and you won't get any aspirates. And biopsy is required to make a diagnosis. So, these are what you are going to see in the biopsy. So, it is straightforward to diagnose. We also have a polycythemia study group has defined the diagnosis clearly. These are the criteria to make a diagnosis. There is splenomegaly, which will be massive, fibrosis. If you do bone marrow aspiration, is dry tap. Then a leukoerythroblastic picture, you see immature red cell, immature white cell in the peripheral. Then there is no polycythemia because you have to rule out that there is no polycythemia. There is no increased red cell mass, and there is no Philadelphia chromosome, no BCR-ABL. You have to be sure that you are not dealing with CML that can also present in a similar way, or you are not dealing with polycythemia. Okay, and then you have to exclude other causes of massive splenomegaly. that anything that can cause, you have to be sure they are not there before you say okay, patient has myelofibrosis. If the patient has had polycythemia before, say okay, secondary myelofibrosis. If there is no history of polycythemia, it is primary myelofibrosis. Okay, so it's just to exclude. So this is the treatment. One is for one, two is for two. If there is hyperuricemia, you use allopurinol. If there is anemia, you use androgens or corticosteroids, steroids, transfusion. If there is severe thrombocytopenia, you do splenectomy. How will that assist thrombocytopenia? Splenectomy. How will it assist thrombocytopenia? Sorry. Eh? Platelets. Third of the platelets is stored in the spleen. So if you remove the spleen, it will release the content into the circulation. So these are the other treatment modalities. Splenic pain, you can do splenectomy for that too, or splenic irradiation, or portal hypertension, you do splenectomy for that too, because it's going to affect the liver. And severe hypermetabolic symptoms, you use chemotherapy such as busulfan. Hepatomegaly after splenectomy, chemotherapy, and symptomatic thrombocytosis, chemotherapy or anaradromide. So depending on what you are faced with, the condition and the treatment. 5 is for 5, 6 is for 6, although they are not aligning with each other. So that is the way forward. So we'll talk about essential thrombocythemia, and then we'll continue after this next week. So similarly, just like you have elevated red cell, we also have elevated platelets because of mutation. Mutation can also cause the platelets to go up. It is different from reactive or secondary thrombocytosis. What are the causes of secondary? You have secondary polycythemia, you have primary. You also have secondary thrombocytosis, you have primary thrombocytosis. What are the causes of secondary that is not cancerous, not malignant? Secondary thrombocytosis that will cause platelet count to go up. Hmm?
Road traffic accident.
Okay. Uh, when there's blood loss that can be reactive, patient is losing blood and platelet can go up. Why? What has blood loss got to do with thrombocytosis? When there is blood loss, the body will stimulate what? Will stimulate to compensate for the loss. Stimulate what? Eh? Eh? Erythropoietin. His body will stimulate erythropoietin. Erythropoietin will stimulate erythropoiesis and thrombopoiesis because they have a structural similarity. So that's why it is secondary thrombocytosis. Okay. Iron deficiency anemia can also cause secondary, because anemia too will also stimulate. What other thing can cause secondary thrombocytosis? You have said it just a few minutes ago. Spleen. If you remove the spleen, splenectomy for any reason, splenectomy can cause secondary thrombocytosis because platelet is stored, one third of platelet is stored in the spleen. So if you remove the spleen, that storage facility will be lost. Okay, so it's different from malignant production. There's a mutation, that is the primary or essential thrombocytosis. Usually the platelet count in malignant is more than 600,000, usually more than 600,000, unlike in reactive thrombocytosis or secondary thrombocytosis. In malignant thrombocytosis, platelet count is usually 700,000, 800,000. What's the normal platelet count? 150 to 400. Okay. So, but it can be 1 million. In case of essential thrombocytosis, platelet count of 1 million, 1 million 250, 1 million 500. Platelet count 2 million. So it's a malignant form. It's also a disease of the elderly. It's seen between 55 to 60 years. Okay, and these are the usual mutations associated with essential thrombocythemia. I talked about calreticulin R, calreticulin R, and MPL is myeloproliferative leukemia mutation. MPL, myeloproliferative leukemia, are found in 90% of patients. MPL. So this is how to diagnose primary or essential thrombocythemia. So it's a disease of the elderly. So, but the platelets that are produced are abnormal in function. Apart from the fact that they are elevated, they are also abnormal in function. You have plenty of platelets, but they are not working well. So patient can also bleed despite platelet count of 1,600,000, 700,000. Patient can also bleed. So the spleen will also be overworked because the spleen is trying to mop up these platelets and cause enlargement. Okay, so to make a diagnosis, you have to rule out. So these are the causes of secondary thrombocytosis: iron deficiency, hemolysis, chronic inflammatory disorders I've mentioned, post-plecectomy, cancer generally can cause secondary thrombocytosis. And these are the primary causes of thrombocytosis: essential thrombocythemia, polycythemia rubra vera, myelodysplastic syndrome, we should talk about myelofibrosis, chronic myeloid leukemia. So these can cause all the platelet to be elevated. You can see the platelet count, the publish. These are the platelet in publish. It's filled, the peripheral field is filled with platelets. And you know something, is this reactive? Is this secondary? Is there mutation? But by the time you are getting platelet count of 700,000, 800,000, elderly, just ask for those mutational analysis, JAK2, CALR, and MPL. But can be negative because just like you have a polycythemia rubra vera, JAK2 is not seen 100% of them, can be 95%. You still have few, but you still need to rule out that there is no CML. BCR-ABL is negative. You still need to rule out that it is not myelofibrosis. So once you rule out, then you can say, okay, maybe it's ET. That's essential thrombocythemia. And this, you can see the megakaryocytes. If you do a bone marrow, unlike in myelofibrosis where you are going to get a drop tap, you will get tap, you get and you see plenty of the megakaryocytes. You know there is and uncontrolled production of the megakaryopoiesis. Okay, and this histology is also due to the mutation that is causing so like just like I said, you have to be sure that platelet count is elevated and then there is increased megakaryopoiesis in the marrow to confirm the diagnosis. Then the BCR-ABL is negative to rule out CML. Then there is no marked dysplasia to rule out MPS because all this can cause elevated platelet count. Okay, then if you can demonstrate JAK2, then it's good, and then JAK2 is positive because JAK2 or absence of JAK2 does not rule it out, but if JAK2 is positive, you can say okay, it is, and there is no polycythemia. JAK2 is positive, no polycythemia, and there's elevated platelet count. You can say okay, it is ET. I hope that is clear. So how do you treat these are the guideline, WHO guideline you can use depending on whether the person is less than 60 years or older than 60 years, whether there is associated because platelet elevation can cause vaso-occlusive crisis just like it just like a sickle cell or hemorrhagic crisis. The platelet count is high but they are abnormal platelet function because they are not properly produced, and then they can cause hemorrhage. Then vaso-occlusive crisis can cause thrombosis of the retinal vessels, of the ear vessels, of the brain vessels, can affect the vessels of the arteries, and can affect the veins, can cause DVT, can cause phlebitis, can cause cerebral thrombosis, mesenteric thrombosis, retinal thrombosis because of the viscosity, hyper viscosity that is because the vessels is packed. If you have 1 million platelet count, 1 million, and it should not be more than 400, then the vessels will be packed and they can occlude microvasculature. So depending on whether you have uh, thrombosis or not, whether you are 60 years or not, you can use this to treat. Hydroxyurea is also good for treatment, just like in polycythemia rubra. But they say okay, hydroxyurea can cause secondary malignancy too. So, and it's not safe in pregnancy. So you can use this anagrelide because it's safe in pregnancy. Because we see pregnant women with essential thrombocythemia. That one can cause death easily. Low dose aspirin is also useful. Okay, this is another algorithm you can study depending on whether the person is 60 years or less than 60 years, above 60 years, and whether the platelet count is 1.5 million. Platelet count is 1.5 million or less. You can use this, or whether the person, if it's less than 1.5 million, person is less than 40 years, you can do watch and wait. And if it's more than if the person is 40 to 60 years and platelet count is less than 1,000, you can consider treatment, and then you can use your discretion based on this algorithm. This is also from WHO, so you can decide whether you want to use hydroxyurea, whether you want to do anagrelide, whether you want to use low dose aspirin, whether you can do phlebotomy too. You can do phlebotomy, and then you can do platelet pheresis. Platelet pheresis, you just draw out only platelets. Okay, so depending on what you are not expected to treat, but you should know this is another algorithm for treatment based on age, based on complications, based on the platelet count. So depending on what you have, you can decide to use. You also use pegylated interferon. Peg IFN is pegylated interferon. Pegylated interferon based on age and based on complications. So this is pegylated interferon, and you can do watch and wait too. You can say, okay, let's wait, let's see what will happen, particularly if there is no complication. So I think that's all.